So thanks for presenting that case. This is really, as you said, a very classic case of acute graft-versus-host disease, but does bring up a number of questions that we can ask regarding this case of acute graft-versus-host disease. Some of the things that we can talk about, and we're going to ask you to review, is understanding how we stage or grade this patient's graft-versus-host disease, your approach to whether this patient required a biopsy or histologic diagnosis, and then what are the alternative treatment approaches that you could have considered for this patient, and understanding that if this patient was treated with steroids, what would the prediction be for the likelihood for him to have responded? And with that, I'm going to pass it back to you, and you'll take us through some of these questions.
Indeed, Corey. So I think the first question is this: day 22, he probably just engrafted. He has skin rash and diarrhea. Is this graft-versus-host disease? Is this acute graft-versus-host disease? It probably is. But what if it is not? What could that be? Chemotherapy effect, engraftment syndrome, drug effect. The majority of our patients get neutropenic fever and they start on antibiotics. And this is probably the tail end of the antibiotics. So it could be many things. Should we biopsy this man? Can we do a skin biopsy, and should he go for a colonoscopy? I think he should. And the reasons are, I just moved to my new job here from New York, where we did T-cell depletion. And that diarrhea could indeed be something else. It could indeed be CMV infection. And you don't want to, as this case showed, you don't want to commit this man to a huge burden of steroids for a long time while he has something like CMV colitis, or even worse, adenovirus colitis.
So I agree with you entirely, and I suspect Dan does as well. But let me ask Dan a question. Dan, if you chose to do a biopsy, would you wait for the results of that biopsy before starting steroids in this scenario?
Well, that's a great point. No, I wouldn't. I would get the biopsy. And I know there are differences in opinion there, but not delay therapy for, the result of the biopsy.
I agree, and I suspect, Usama, you do as well. Why don't you tell us, though, how you stage and grade this? You alluded to body surface area, but why don't you formally run us through how this patient's GVHD is graded?
Sure, Corey. I must also add that the majority of these cases come on a Friday afternoon, right before Memorial Day weekend. So waiting can get things worse while you're waiting for that biopsy colonoscopy on a Tuesday. So I think we all have a consensus that while a biopsy is a good thing, it's not we should not wait, and we should treat before the genie is out of the bottle. There are many staging and grading classifications for acute graft-versus-host disease. In my current institution, as well as my prior institution, we use the oldest, the Luxembourg grading, which dates back to 1974. It's adopted many times in more recent staging and grading, most notably the MAGIC Consortium, the Mount Sinai Acute Graft-versus-Host Disease International Consortium, which is, again, it's an adaptation of more than a 40 years old staging and grading system. In a nutshell, as you said, Corey, the three main organs, only organs that get affected by acute graft-versus-host disease, classic acute graft-versus-host disease, are the skin, the gastrointestinal tract, and the liver. Per organ, it's considered a stage. So we stage the organ, then together we get a score or a grade. So just like our man here, he has 60% of his body surface area involved. That is skin stage 3. For bowel movements, that is a GI stage 1. Together, that makes up for a grade 2 acute graft-versus-host disease.